Welcome to On the Beat, the pulse of gynecologic oncology, brought to you by the Regroupement des Gynécologues Oncologues du Québec, RGOQ. Before we begin, a brief disclaimer. This podcast is supported by an unrestricted educational grant from AstraZeneca. The content, expert selection, and topics discussed are fully independent, and the opinions expressed are those of our experts, free from any influence by AstraZeneca. This discussion is intended solely for healthcare professionals and is for informational purposes only. It is not medical advice and should not be taken out of context. By listening, you agree that this content is not intended for patients or the general public. For personalized medical advice, please consult a qualified healthcare provider. Now let's get started and explore the pulse of gynecologic oncology.
Hi everyone of the RGOQ. Welcome to the first of a series of podcasts that I've been asked to host and introduce. So I'm here today. I'm Dr. Pirivanti from Serena, as most of you know me from Hôpital Maisonneuve-Rosemont. I'm a gynae oncologist, and I'm honored to be joined by one of the pathologists from the MUHC, Basile Cloutier. And we thought today we would touch upon a very important topic, very upcoming topic, which is molecular markers and molecular testing, and we're going to survey most of the cancers and more from a practical standpoint. So welcome, Basile.
Thanks so much for having me.
And so we know you've been a pioneer in on a lot of committees and implementation, and we're going to discuss today about like what's up and coming. And so a lot of talk right now is on POLI, and everybody wants to know the POLI status. So it's just from a practical point of view, like how is it done and when should it be done?
Yeah, there's a long list of testing that's emerging now for GYN. I think it's a very exciting place to be. There's, a lot in the pipeline as well coming up. As far as POLI, I will say, it's been a revolution since the paper in 2013. And really now I think we're doing a much better job at implementing it on a routine basis. So as far as the current, testing logistics that we would do now for POLI at the Glen is using essentially endometrial cancer biopsy tissue. Then we will sequence this, and then based on the result, then we will add an addendum report, and that's when you'll see, and then you'll get notified about the POLI status. Mm-hmm. Now, the timing of doing the POLI, that's where where it becomes very tricky and very controversial in a way. I think depending on different setups in different hospitals in different provinces, they will have different approach. As you know, for POLI or any molecular testing, the basis is we want to do a test at a timing where its interpretation will impact patient care, right? So that's the whole point of POLI. And in that context, we certainly want to have a result before the time of making decision for adjuvant therapies, right? So in certain, system, this is very viable to do at the time of resection. I often argue in our current system in Quebec, doing it at the time of biopsy makes a lot of sense. I'd love to hear sort of your experience on that aspect.
For sure. And we spoke a little bit offline. Yeah. Like for me, I get your pathology reports from our patients from outside, and it's perfect because now it's not just like grade 1, grade 2. It's really like we want to know everything right away. Yeah. MMR status, hormone receptor, POLI, HER2 new, and like it's kind of like all blah, 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 all like in one sentence. And you're like, this is perfect. I have like all of the prognostic information I need about my patients. And I agree right now, it's actually not yet. We're hoping we're doing rainbow green. We're doing all the rainbows and trying to de-escalate treatment. So we're hoping these will help us de-escalate adjuvant treatment. But what about earlier? So like, for example, EIN, endometrial hyperplasia. So right now, like we do sentinel lymph nodes, but could having some molecular analysis help us decide what kind of surgery we do if we take them for surgery? And I was actually just reading a paper recently, and that was just published in an international journal where they looked at the fertility sparing population and they stratified them. So of course they're very small number. There are only 33 patients. But it's actually interesting that the POLIs were the one that recurred. And so which is the opposite of what we think in typical endometrial cancer. So I feel like there's a lot of work coming and a lot of prognostication that's going to be done, even like from the beginning. Like this is what's used to identify a patient. And even in all of our clinical notes, like that's the first line of our clinical note. It's, like 73-year-old, grade 1, P53 wild type. And now we're adding the poly, of course, right? And it's kind of like an ovary where it's always like the BRCA status is also like the introduction. So I think that that's kind of where we're going, and that's what people will want to know. And as well, like for example, HER2 new, I don't think people really know like what's the process of testing, like what do you guys do? And
right. Yeah, no, and just to wrap up what you're saying about poly, I think, that certainly right now, we will do it it has to be for an endometrial cancer diagnosis. EIN right now is definitely, is not part of that testing algorithm. And technically we would want to test cases for poly when they are higher stage or have at least risk factors of recurrence, right? And that's when you sort of make the decision as far as adjuvant therapy. But at the same time, the timeline to make that decision is only a few weeks after resection, right? So in the current setup, we have, the delays that we have with the processing of the tissue make it very difficult, especially if it's done at an outside center, to be within those timeline in Quebec. So for endometrial cancer right now, and actually for poly testing, one of the only center that offers it is the Glen at the MUHC. I think JGH had a test. I'm not sure if it's online now, but that means that a lot of people that will have poly testing will be done kind of outside the testing center, which will add a lot of delays. And that's why I think I argue that in the current system, we should definitely do the testing at the time of the biopsy. Now, for HER2, that's also another complicated story that's had recent changes. When it started, with the trial in Yale, showing evidence of response to high grade endometrial cancers to HER2 inhibitors. Now, a lot of this has changed since then, since the introduction of the new therapies, the antibody drug conjugate therapies, where the threshold for HER2 positivity was changed, right? So just to give a little context, back then, when we were testing for like trastuzumab therapy, the HER2 threshold was, we needed to have a positivity of 3+ or evidence of amplification using a FISH assay. So this was sort of the kind of the threshold for access to treatment. Now, this was established using a certain testing criteria that was also developed at Yale, that was actually validated for endometrial cancers. But now with the new therapies, the threshold is, much lower, right? Like the trials, like the Destiny trial came up with saying, 1+ HER2 expression is sufficient for testing. So on your end, if you get a result that's, 2+ or even a 3, like a complete positive, would you, how do you decide therapy? In what context do you end up,
I think that's where the question comes in, right? So if they're HER2 and they're from the Ceres, and like you mentioned Destiny, there's a few trials coming up. And so down the line in clinical practice, which are we going to favor if they're HER2 or DMMR or poly, like which one are we going to favor? And I think people are still kind of juggling that around. And so right now we're in the clinical trial, so we're only kind of, we'd like to know the status, like you said, right away to see if we would offer them one trial over the other. But I think in clinical practice, it's going to be very helpful to decide what we ultimately end up giving them. So the other thing that you touched upon was like a lot of times the biopsies are done outside. And so what do you see as the challenges in each center implementing their own diagnostic assay or like ability to run the tests?
Yeah, for HER2, one thing that helps is that it's an immunohistochemical assay, which is much more accessible for most centers. The interpretation, though, is another thing. So, some pathologists in an outside or community center may not be comfortable with the interpretation of HER2. That said, I will say that, given its importance in breast cancer, I think a lot of pathologists are quite familiar. But certainly, that's another barrier to have a test being accessed or at least offered in a rapid turnaround time. But in the future, in the not so far future, in fact, some of the assay we already run provide amplification status at the genomic level of HER2, right? So that's also maybe an approach. I think most of the trials now still rely on sort of the tried and trusted tests like the immunohistochemistry. So that's why we still see a lot of these kind of assays being needed for access.
And so offline, we also touched upon like the pathway. And so do you do something like the PROMISE trial where you test certain markers first and then others, like reflex testing, or do you foresee that we should just like do them all on the biopsy?
Yeah, that's another related question to the poly. I think it's for the HER2 in a way. I think we can argue that the amount of cases that are typically reflex tested are relatively uncommon. So we're talking mostly TP53 mutated endometrial cancer. So in that context, again, the usual practice is to test it reflexively. But things will change now that we start rolling in maybe the antibody drug conjugate drugs, and now maybe we, in a given case where there's an indication to use it, maybe we want a HER2 in a lower grade, malignancy, maybe that's advanced or so on. So I think we will need to have a very close communication in between, the clinical team and pathologists, and try to really understand which case you want to have a HER2 status, especially given everything else going on, because based on certain trials now, it's not really, it's essentially can be site agnostic. So we'll have to see for that.
Well, definitely the landscape of endometrial cancer is changing. It's super exciting. So I think like the molecular testing, as we do pretty much as from a clinician point of view, we definitely want to know them all from the beginning. And I look forward to seeing how each center will be able to implement this, and if it the system can take it up.
Thank you for joining us on the Beat the Pulse of Gynecologic Oncology. We hope today's episode offered valuable insights. For more content and to stay informed, visit us at rgoq.ca. Until next time, stay informed, stay connected, and continue advancing the care of women with gynecologic cancers.